So I wanted to share that with you guys. Was that helpful? Yes? Okay. Okay. So again, a lot of questions, and we need more funding for heroin research. Okay, so let's move right along to why medication-assisted treatment should be an integral part of the treatment for opioid use disorders. So I think one of the main problems with medication-assisted treatment is that many people have taken the assisted out of the definition, and they just think about it as medication treatment. And so that's why sometimes maybe we should be thinking about calling it medication-assisted recovery. And so for me, really, both terms or both terminologies, I use them interchangeably. But what it is the use of long-acting medications in the same class as the abused drug, with the goal of not only preventing a withdrawal syndrome, but we're helping with craving modulation, and again, sort of helping the brain to heal while people work and do their psychosocial work and help get their lives together in other ways. What medication-assisted treatment really isn't is substitution of one addiction for another or one drug for another. And SAMHSA really summarizes and says it best, right? MAT is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. And we know that combination of both medication and behavioral therapies are really what give our patients the most success. So in the end, we don't want, docs in a box, giving the same treatment to everybody. We want individualized treatment, and it's really sort of a combination of pills and skills. And so the medications that we use for the treatment of opioid use disorders are methadone, certainly through methadone maintenance, buprenorphine maintenance, extended release naltrexone as an opioid antagonist, and LAM, which is alpha-acetylmethadol, was actually taken off of the market for because of a black box warning for cardiac arrhythmias. So unfortunately, it's one medication that we no longer have available to us, but we do have the other three options. So who is appropriate for medication-assisted treatment? Well, in the case of methadone, anybody 18 years or older. There are exceptions for 16 or 17-year-olds with parental consent or emancipated minors as well. But they do require a year of a one-year history of proof of physiologic dependence. In the case of buprenorphine, it's approved for ages 16 and older, and you do need to meet, of course, DSM criteria for an opiate use disorder. People that have been unsuccessful at abstinence trials, again, based on our clinical experience and the data that I've shown you before, people that are chronic relapsing are good candidates for medication-assisted treatment. Certainly medically compromised patients and patients with infectious diseases, and last but not least, definitely pregnant women, and we will be talking about that later on. So what about the role of counseling? Well, fortunately for all of us that do therapy in the room, therapy, 12-step approach, therapy have been the standard recommendations since 1965. And Ballen-Ross and McClellan, David Filene and Roger Weiss, and there's numerous studies to support that. So in no way, shape, or form will you ever hear me give you the message that therapy in 12-step is not needed. We absolutely need to incorporate that as part of treatment. But the reality about medication-assisted treatment, even though we don't have a lot of data of its use in residential treatments, is that 30 to 50% of residential programs really aren't, talking about medication-assisted treatment and educating their patients. We still have, some programs and treatment approaches that are abstinent-based only, and that can be sort of scary to me in patients that are chronic relapsers and have tried abstinence-based programs, and that doesn't work. And among adopting programs in the private sector, only about 34% with an opioid use disorder actually receive one of the FDA-approved medications for their treatment. And so here I do want to see a show of hands on what really ends up being the biggest barrier to prescribing MAT in a residential treatment. And the first one is, it's not in keeping with our philosophy. Show of hands. Has anybody heard that at their programs? Okay. You're just substituting one addiction for another? Okay, a few more. People should try being off of all medications first? Okay. If we give it to one patient, they're all going to want it. All right? Okay. And last but not least, you're not really in recovery if you're on medication. right? That's where I probably see the biggest hands in the room. Agreed. And I think it's lack of education that's really the biggest, and sort of personally, held beliefs that aren't evidence-based probably are the biggest barrier to incorporating this into mainstream treatment. And so when I first arrived to Spring Hill about 2.5 years ago, one of the biggest obstacles that I faced was trying to make nice, I was a new kid on the block, and there's been staff that had been working there for a lot longer than I had, many of them in recovery. I had to make nice and do a lot of presentations similar to this one to my staff, so that not only the medical staff, but all of the staff that worked with patients knew about medication-assisted treatment and the brain, so that if questions came up, with our patients, there wasn't sort of splitting going on. So it's important to keep everybody on the same page. We not only train our staff, but we also educate our patients. Every other week they get a presentation directly from me or from my nursing or nurse practitioner staff, educating them not only on addiction as a brain disease, but on the role of medications. Once a month we have a family weekend where loved ones, spouses, children, of people that are in treatment with us come for a family weekend, and they too get a lot of education and a 3-hour presentation on the brain, addiction, medications, and whatnot. So there's a lot of places to get additional support. PCSS MAT is a good resource. Have any of you guys used that? Okay, well, I'll talk about that towards the end. So we at Sunspire, our position is we actually agree with SAMHSA and NIDA, and that medication-assisted treatment not only should be offered on a routine basis, but it should be the standard of care. Again, not to beat a dead horse, but because the relapse rates, are so high, with mortality rates of 80 to 90% within the first year after leaving treatment. So how do the medications that we use for medication-assisted treatment work? And so for this, I'm going to give you guys a real crash course in psychopharmacology. And I've tried to sort of simplify it so that if any of you want to use any of these slides or handouts, with your patients, you can explain it to them in the way that I do. I keep a copy of my presentation on my laptop at all times, and so whether it's with my private patients or patients, at Spring Hill, if questions come up, I have those slides, those brain slides, ready to go to explain things to them. So probably the best way to understand how these medications work, again, is by understanding the function of how opioid agonists, partial agonists, and antagonists work in the brain. And to do so, I've done the green light, yellow light, red light model. So in a green light represents an opioid agonist. So, and these little diagrams here are your mu opioid receptors. So when a medication like morphine, methadone, heroin, or oxycodone, which are full agonists, bind to that opioid receptor, you get its full effects, full euphoria, full pain relief, but also a greater risk of overdose. With a partial agonist, there's again partial binding to that mu opioid receptor. The best example, of course, here is buprenorphine. And so with a partial agonist, you only get, again, partial activation. You don't get as much euphoria or pain relief, from a partial agonist. But you also don't have to worry, or there's less concern, certainly, about the risk of overdose because of that property. And then certainly an antagonist, and examples here are Naloxone or Narcan, are substances that bind to the opioid receptor but just completely, shut it off or block it. And that's why I've used sort of the red light example for this one. So again, the green light, highly reinforcing, full agonist binding, it's the reason why full agonists are the most abused opioid type. We talked about, again, partial agonists, which are safe and include buprenorphine, and then again, the antagonists with the red light. Probably the most important distinction from a safety standpoint when we're talking about the mu properties are what you can see on this slide. If you look at on the x-axis, the dose of the opiate, and on the y-axis, the opiate effect. On a dose response curve, when somebody is taking a full agonist, the higher the dose of the agonist, right? The more you go up on your dose of morphine, heroin, oxycodone, the higher the risk of respiratory arrest, because it goes up on a linear dose response curve. With a partial agonist, they have, especially again, buprenorphine, the example, it has a property known as the ceiling effect, which at a dose of 32 milligrams, it's its maximum dose. And really prescribing anything beyond 32 milligrams not only gives you any additional benefit, so doctors shouldn't be prescribing more than 32 milligrams because physiologically it's not going to do anything or having the effect, and that medication is lost. But you really can't overdose, right? And so the overdose deaths that have been reported with buprenorphine or Suboxone have really not been on people that have been using buprenorphine exclusively, right? The deaths that were initially reported in France were from people that were mixing, buprenorphine with benzodiazepines, with alcohol, were injecting it, and so it was really sort of difficult to clarify what the cause of death really was. And of course, with an opioid antagonist, that you don't have to worry about anything on a dose response curve unless people try to overcome that opiate blockade. So let's move along and we'll talk about methadone maintenance. Methadone maintenance we talked about before. Dole and Niswander in New York realized that in communities where you prescribed methadone maintenance to people and they came and they got their daily dose and you offered them the psychosocial support that is a requirement at every methadone clinic, and they're very tightly monitored, to make sure that people aren't just going and getting their dose every day, but again, that you're incorporating the psychosocial support, that you're in drug testing as part of it, is that people did really well. And the studies continue to show that even comparing methadone maintenance to buprenorphine maintenance, the treatment retention rates are higher in methadone maintenance, and part of that probably has to do with a lot of the structure that goes along with, and again, a lot of the psychosocial support. If we had treatments like that for hypertension, right, that would be terrific, right? That we could actually make sure that our patients were taking their antihypertensives every day. But replicating a model like this is difficult to do. But again, some of the advantages of communities where methadone maintenance has been incorporated is that not only are we decreasing return to opiate use, but we're allowing patients to go back to work because they're not having cravings and going into withdrawal every day. There's decreased needle sharing, therefore there's less transmission of HIV and Hep C and other infectious diseases. And so, there's overall certainly improved outcomes. It has for a very long time been the gold standard in pregnancy, and even though buprenorphine is approved as well, the take-home message is that maintenance should be offered to any pregnant woman. So let's talk about buprenorphine maintenance. And of course, it goes without saying, I'm sorry, that the main limitation, as we know, for methadone maintenance is that, the fact that there's a lot of communities where patients, have to commute an hour or two to get to a facility to get their dosing every day. So not being able to have it be in an office practice is a big limitation. And certainly methadone for the treatment of addiction is something that has to be done out of a clinic. It cannot be done out of a doctor's office, and you can get in trouble if you're prescribing methadone from your practice, for the treatment of addiction. So what is buprenorphine? So, call me a nerd or whatnot. Buprenorphine is probably one of my favorite medications, just because I think that the way that it was designed is almost sort of brilliant. Again, it's not left without its problems, but its design was really intended to be a really brilliant medication. So what is buprenorphine, naloxone, and here I will use the brand name Suboxone. So it's really a combination of two medications, buprenorphine and naloxone. It's a Schedule III partial mu agonist, which was approved in 2002. And like methadone, it can substitute for a full opioid agonist and alleviate the symptoms of both withdrawal and cravings. And so I say that it's a brilliant medication because when it is taken sublingually as prescribed, the buprenorphine is really what takes effect and what is active, because the naloxone is really an antagonist. So if you try to snort it or inject it, technically the opiate antagonist effect will kick in. But if you take it sublingually as prescribed, the buprenorphine will have its active effect. I included this slide here just to show you, this is my best representation as I could of a mu opiate receptor in distress from withdrawal and from cravings, and how it can settle down once you administer buprenorphine, and no longer is that person that's taken the buprenorphine, again, feeling the distress and dysphoria from withdrawal or from cravings once they've taken their medication. And naloxone was included again as a safety feature, and with the goal of having it be a deterrent to abuse or misuse. So it hasn't been perfect. The nature of addiction is to try to defy and defeat whatever you've been told to not do something. So we've all heard of patients of ours that have tried to snort it or inject it, but pharmacologically, technically it's not supposed to work, although many of them do report that they have been able to get a high from it. One of the interesting properties of buprenorphine is that it has a very high receptor affinity for the mu-opioid receptor, meaning that when it binds to the opiate receptor, it sticks onto it like crazy glue, right? So if somebody has taken their dose of buprenorphine in the morning, and later on they try to use heroin, for instance, as long as that buprenorphine is stuck, to that receptor like crazy glue, it's like you've wasted your money. So it has sort of a protective effect that way, and that's why the higher success rates, or the high success rates that we used to see at Children's Hospital, were in part because we had the parents hold on to the medications at all time and do supervised dosing. So at least for that day, they knew that their child had not only taken their medication again, and it was helping them with cravings and with any potential for withdrawal symptoms, but that in the event that they tried to use any other opioid, it wouldn't be able to bind there because the buprenorphine was there. And that has to do with its receptor affinity. On the flip side, if somebody has used an opiate, used heroin or a prescription opiate, and then takes buprenorphine, it bumps it off of the receptor and you go into withdrawal. So timing is everything, especially when doing an outpatient induction and starting patients onto a maintenance dose of buprenorphine. As I mentioned before, it has nonlinear kinetics, meaning on a dose response curve, at a higher dose, you don't have to worry about a higher risk of overdose. Its maximum daily dose is 32 milligrams, although most patients, believe it or not, do stabilize somewhere between 8 to 16 milligrams. So, and I've been doing this since 2002 myself, and I've prescribed buprenorphine to a lot of patients. And I can tell you that I can probably count in the palm of one hand the number of patients that I've had on doses higher than 16 milligrams, right? And there's a lot of diversion of buprenorphine or Suboxone, and oftentimes I do think it comes from patients that are being prescribed 24 milligrams for every single patient in the practice, or doses certainly higher than that. And pharmacologically or biologically, we know that as you can see on this slide, that human brains really don't need more than 16, 18 milligrams at maximum. This is a slide that shows you the mu receptor ability, which is seen in these brain slides as green. And as we see, as you go up on buprenorphine dose, the number of mu receptors saturation increases. So most opiate receptors in your brain are saturated at a dose of a maximum of 16 milligrams. Anything beyond that, you're really not getting a lot of bang for your buck. There's different, as you know, you do need to undergo an 8-hour training. It can be done online or in person through ASAM. ASAM offers an 8-hour training. Initially, there was a 30-patient limit, but you were able to, after a year of prescribing, the limit was increased to 100. And there's been recent, recent conversations about really increasing that patient limit to 275 patient limit for people that have that are board certified in addiction psychiatry. They have a board certification through ASAM. This is not official yet, but it probably will be happening sometime soon. So buprenorphine does come in 2 presentations. The most common one that we know is Suboxone, which again is the combo product of buprenorphine and Naloxone. So that's the presentation that we want to be prescribing, because it includes the deterrent factor to it. The mono tablet or the mono film of buprenorphine should really only be prescribed to pregnant women or to people that have a known allergy to Naloxone. And I can tell you, allergies to Naloxone are extremely rare. So essentially, when I talk to people, talk to doctors around the country, if your patient is asking you for the buprenorphine alone, the Subutex alone, I'm always weary of the intent behind it, because that's a presentation, of course, that's more easily abused or diverted. So it's interesting, and and well, I guess I'll go back and I'll say I'm really an optimist, right? And so what I like about the pharmacology of buprenorphine is that I can tie it and it can go hand in hand with my treatment goals when I work with patients. And so I know it's a medication that's not devoid of problems. And there is sort of the good news, the good, the bad, and the ugly that goes along with it. What do you guys want me to talk about first? The good, the bad, or the ugly? The good. Okay. Okay, so we have some half-empty people and we have some half-full people in the room, trying to figure out what people's dopamine levels are at. Okay, let's start off with the good, right? So the good is that I can match it up to my treatment goals, which are really to suppress withdrawal, to block or attenuate the euphoric effect or the high, and to help people with cravings, and to eliminate the cravings for other opioids, to decrease the relapse rate and overdose rate, to decrease diversion, decrease the transmission of HIV, Hep C, and other infectious diseases, and to really help my patients function in all spheres of life. And the pharmacological properties of buprenorphine allow me to do that. Other good things is that compared with methadone, it's been shown to be helpful both in detox and maintenance, and it's better tolerated overall. We have, even though there's slightly, again, better treatment retention rates with methadone, patients that are on buprenorphine maintenance do better than patients that aren't. And it can be prescribed in a doctor's office. And that availability, that capacity, is something that's very comfortable for patients. I certainly am somebody that runs a very, tight Suboxone practice, so I don't start giving patients a month's supply at a time. I really like to get to know my patients, and so I start them off. I do a face-to-face induction. I start off with a few days or a few weeks, a week's prescription at a time, and I meet with them regularly until I have them on a maintenance dose. And it's only once via compliance with 12-step meetings, with therapy, with urine drug testing. That once they're doing better, that I feel comfortable giving them a month's supply at a time. But that certainly happens down the line. So again, that availability of being able to do it in your office has sort of both sides of the coin. The bad, of course, there's significantly more diversion from buprenorphine than from methadone. In a study in Australia, they showed that there was a 10 times greater risk of diversion of buprenorphine versus methadone. French studies showed that diversion was up to 20%, although it might be, in reality, I think it might be higher. But there was a parallel decrease in death, which was important. Probably another bad thing is that it's sometimes difficult to taper patients off when they're at their lowest dose. So it's kind of like getting them off of that last cigarette. It's helpful to help people in their, cut back from their first few cigarettes, but it's that last one, just like the last 2 milligrams of Suboxone, that are difficult to get people off. So my rule of thumb and my recommendation to people is to really never do quick tapers, whether it's be it from somebody that's in a methadone clinic or that's been on buprenorphine maintenance. I try to keep my patients on maintenance for at least a year, because I think it takes at least that period of time for them to start getting their lives back. And then if and when we do decide that tapering is needed, we do it very gradually by like 1 milligram a month or every other month. That way your brain can't really tell the difference from when it's going down from 16 milligrams and gradually and eventually going down. Now I have the conversation with my patients also about, why do they want to get off of buprenorphine? Because there are some people that are able to get off of it and eventually go onto Vivitrols and Antagonists to help protect them afterwards. But there's some people that don't, and maybe all they need, just like some of us have to take a medication for thyroid problems or for high blood pressure, for diabetes, maybe all it takes is 2 to 4 milligrams to help you maintain your abstinence and your recovery. Because I have seen, unfortunately, people that stop their, even after enjoying 3, 4, 5 years of being on buprenorphine maintenance and doing well, that come off of it and do relapse. And so last, of course, the ugly, that many patients do use buprenorphine sometimes to perpetuate the cycle of addiction, right? And they'll stay on their buprenorphine or Suboxone Monday to Friday and use heroin and other opiates on weekends. And the ugliest of it all is the creation of pill mills, that I'm embarrassed to say, right, that colleagues of mine have turned this into an opportunity to enhance their lucrative practices instead of really an opportunity to offer help. So this is a study by Keiko in 2003. It's probably been the longest study that's been done, comparing buprenorphine for withdrawal versus maintenance. Both people and it was a double-blind placebo-controlled study, and patients in both arms received a 7-day detox with buprenorphine. There was one group that went on to continue on to maintenance, and another group that was just discharged after the 7 days of a detox and went on to receive psychosocial support. As you guys can see, very quickly those that just completed detox relapsed and went back to using, as compared to those that were kept on maintenance that did better a little bit longer. One sad thing about this study is that 4 subjects in the control group, which was accounted for approximately 20% of those in that group, did die. So we have to remember that this is a lethal disease that we're talking about. I know there's a lot of controversy about prescribing buprenorphine to adolescents, but in this study from George Woody at the University of Pennsylvania that looked at 156 youth ages 15 to 21, and it was, and again, also a randomized control trial. There was one group that underwent just a 2-week detox, and there was another group that had 12 weeks of maintenance treatment. And what we see here, which is really interesting, is that the orange group in detox really quickly after completing their inpatient detox started to relapse and had significantly high relapse rates even a year out. Those in the maintenance group, interestingly enough, did very well, and they were kept on maintenance for the first 8 weeks. At week 8, they started tapering them between week 8 and 12, and what do you see happens here as soon as they start tapering them? They start to relapse. These kids started to relapse. So between weeks 8 and 12, as you can see in the line there in green, they started to relapse, and once they completed, and they were all, at week 12, they were completely off of buprenorphine. Their rates started to begin to parallel those that had just undergone the detox alone. So as we try to think about how long should we keep patients on maintenance, maybe the answer is that longer is better. A quick word on methadone maintenance and buprenorphine maintenance in pregnancy. The answer is yes. Right? It's important to know that that opioids are not teratogenic. Right? They don't cause physical malformations to an unborn child. What really harms an unborn child are the cardiovascular fluctuations from using and withdrawing, and those are the things that that are problematic. So by keeping our pregnant women on methadone maintenance, which has forever been the gold standard, or thanks to the mother study that was done a few years ago, which helped to confirm that buprenorphine was a safe option as well. The gold standard is evaluate your patient, try to see which of the two is the right option. But we do know that not only does it help the mother to receive prenatal care and again to decrease the transmission of Hep C and HIV and other diseases, but it helps the neonate also. And we do have decreased intrauterine growth retardation, decreased NICU admissions, and overall decreased morbidity and mortality. When we think about what an appropriate doctor-patient relationship for buprenorphine looks like, there has to be a good treatment in place. You have to have regular visits. Urine drug testing is like the EKG for the cardiologist. It's important for us in addictions treatment. And to have important diversion controls in place. I do pill counts at visits. I look at the lot numbers, and I write down the lot numbers from the medication that's been given to my patients. I have them bring their empty wrappers. It's not perfect, but it helps me to keep track and make sure that they're being compliant. And patients have a responsibility too to abide by their contract, to take their medications as prescribed, not share it with their friends, do their psychosocial treatment, etc. Quick words on Probufene, the Probufene implant. I have not gone to the trainings that are offered by Probufene. Probufene is the implantable subdermal long-acting version of buprenorphine that's designed to deliver 6 months of continuous round-the-clock long-term buprenorphine. My understanding is that it's probably preferred for patients that have mild to moderate opiate use disorders, or people that are probably in the range of requiring about 8 milligrams of buprenorphine maintenance. But again, there's probably more to come on this as doctors get more comfortable prescribing it. Last but not least, another one of my favorite medications, extended release naltrexone or Vivitrol. And it's not because we were when I did my addictions fellowship, Mass General was one of the key sites, the key study sites for the alcohol approval indication, but because I have really seen that extended release naltrexone really works. As you know, as we mentioned before, it is an opioid antagonist, and it's a 380 milligram a month depot formulation that patients receive on on alternating cheeks every other month. It was FDA approved after a study of 250 opioid addicted patients in Russia. And the main goal with this is, again, the relapse rates are so high that if we have our patients on an opioid antagonist, and if God forbid they do relapse, at least they have an opioid antagonist or an opiate blocker on board that might decrease the risk of respiratory arrest. Do patients still try to overcome the blockade? Absolutely, and that's always the fear that we have. But we do educate them on the risks of that. The biggest downside used to be its cost, but this day and age, more and more insurance companies are approving it. And with the help of touch points, sometimes the manufacturer, Alkermes, sometimes through touch points, gives co-payment assistance to our patients. And again, we do have to balance from a sort of return on investment, the cost of the medication versus what it's going to cost to have somebody go to an emergency room, be treated for an overdose, and go into intensive care unit, et cetera. The biggest actual barrier is patients closing the door on their opiate use for a month or for the period of time that they're on the medication. And of course, getting them from their first injection to their second, the second to the third to the fourth. Because medications don't work unless you take them. And this is really not going to work unless you work your program as well. Even though, there's the two key articles from Krupitsky and Gasfriend and Nunes and their group are the ones that led to the FDA approval and had the safety and efficacy studies. More and more papers are showing up in the literature of helping us to try to find out who the ideal candidate for Vivitrol is. And certainly, some populations where it's very helpful is in patients that have been released from prison or physicians that are being monitored from the board and things along those lines. Indications for extended release naltrexone or Vivitrol, it actually can be first line. And for us at Spring Hill, it is first line for us because many patients have tried and failed buprenorphine maintenance already. And so it can also be for patients who have not had success with methadone maintenance or who don't want to be on opioid agonists. Oftentimes, I tell my patients that you really have maybe one, maybe two chances at doing buprenorphine or Suboxone maintenance well, because the minute that you've abused it and not taken it responsibly, it moves from the category of being a medication that's helpful to you to something that triggers you and becomes a medication of misuse, right? So if you've already gone through that, I don't have a good relationship with buprenorphine, you're probably a good candidate for Vivitrol. And there might be some genotyping in the future that will help us to see who are people that are good candidates for it, but that's not yet something in the horizon. Contraindications are really rare. You just have to make sure that your patients have an opiate-free urine before you administer the injection, because they will really hate you if you precipitate withdrawal from giving them the injection if they have opioids on board. At Spring Hill, we check all of our patients. We do liver function tests at baseline. As long as they don't have their LFTs 3 times or more above normal, we'll do an oral lead-in of oral naltrexone. The Alkermes doesn't say, they don't require that you do an oral lead-in, because adverse reactions to naltrexone are rare, but I have seen a few patients that have it, so I'd much rather do an oral lead and have patients be on oral naltrexone for about a week before we give them the Vivitrol injection. And last but not least, the most important thing is the informed consent. We do need to let patients know that that you can have fatal outcomes with opiate overdose, and if you do try to overcome the blockade, sometimes towards the end of the month when the medication is wearing out, that you can relapse and overdose. So we do make sure that all patients wear a necklace or a bracelet or an ID card that does say and that does inform first responders that you're on an opiate antagonist. So as we wrap up, I can't, I'm left sort of wondering, could medication-assisted treatment made a difference for Philip Seymour Hoffman or for Prince? And was it stigma or shame that kept them away from seeking treatment? Because in both conditions, police did find some Suboxone in Philip Seymour Hoffman's house, and I believe there was somebody on the way to deliver that to Prince when he overdosed and died as well. So I don't want to, certainly, as I told you guys before, I'm an optimist, and I do want to leave you guys with a message of hope. And I can think of 10 things that are starting to make a difference. So first of all, it's not what you say, it's how you say it. It's important that we, as John Kelly and Tim Chaney and Mary Woods, shared with us in their presentation, it's important that we really watch, our language and that we use terminology again like substance use disorder and not abuse or dependence. Certainly anything that ends in the word ick has an icky feeling. So we're moving away from using the words addict to somebody that has a substance use disorder that's struggling with addiction. We refer to it as a disease. We don't talk about people being clean. There's no medical condition. There's nothing in medicine, that makes people feel bad for not doing well with their diabetes or their high blood pressure. So having a clean urine is something that we should, or being clean and sober, terminology we should stay away from. The next column, I cannot even say the words that are there. Those are like the F words for me, so I'm not going to even mention them. Thank you. And using words like frequent flyers. This is a chronic relapsing and remitting condition. We're humans. We're not frequent flyers in diseases that are causing us pain. There's been a lot of changes in Massachusetts, starting with Deval Patrick in Chapter 258, which started changing a lot of the way that insurance is the insurance companies approach treatment, limiting a lot of prior auths and permissions to get into detox, so that's no longer a limitation. There's many other items to that law, but I've included the website so that you can look at it. With Charlie Baker, who passed the opioid bill in March of 2016, really started to further the movement of increasing access to medication-assisted treatment, reducing the stigma, trying to include a lot of prevention and education in schools, creating drug take-back days, distributing Naloxone. So there's a lot of movement here in Massachusetts. Even the police department, I think there's been in recent years, fortunately, a lot of movement for first responders to carry Naloxone rescue kits. And so we've seen a lot of change in the stigma, from the police department and first responders, and their understanding that this is a disease and not a crime. And there's a lot of movement, trying to, within various police departments to continue to have that approach and to offer patients treatment and not punishment for treatment. Again, a lot of movement, and I've included a lot of the websites here on, Prescribe to Prevent and Give Naloxone Now. And we had a great presentation by Alex Wally yesterday about Naloxone and its role. I don't have a slide on the benefits from Naloxone in Massachusetts, but in this slide from San Francisco, we can see that in 2002 and 2003, when Naloxone distribution began, there was a significant decrease in overdose deaths. There's people like Joanne Peterson, who founded Learn to Cope and who's helping a lot of families in giving them support around Massachusetts, and Dr. Ruth Potey, who's a physician in Massachusetts that goes around schools lecturing to patients and parents and families. There's a lot of great literature that continues to come out from people sharing their recovery stories and trying to offer help from their knowledge. Public service announcements, stop addiction in its tracks, and a lot of help from AAAP, ASAM, Trooper's Guidance, and Trooper's Foundation, and the support that gives to the community. The work that C4 is doing. The additional support and education services that you can get through PCSS MAT and PCSSO online. These are free services that are extremely useful. And last but not least, the work that all of you guys are doing in this room. And I really thank you for being here, today, and for doing the work that you do, and for giving your patients the message of hope and recovery. Because I think it's important that we remind people that you can get better, that there are different paths to recovery, to have people not lose hope, to remind people that your receptors, that the best way to increase dopamine is through connection, right? They say that the opposite of addiction is connection, and the best way to increase dopamine receptors is, fall in love, go back to school, share time, with your family. Have a purpose in life. That's really what's going to make a difference. So recovery is possible, but it takes a lot of good people like you guys to make it happen. So thank you for being here, and if you have any questions, I'll be staying by.